Hi students, welcome to EPG Pathshala. My name is N. Rekha from the Department of Food Service Management and Dietetics. I am currently working as an assistant professor in the department, and today we will see the module on diet and burns. So to start with, burn injuries are a global public health problem accounting for an estimated 26,05,000 deaths annually. The majority of these occur in low and middle income countries, and almost half occur in the World Health Organization Southeast Asia region. The rate of child death from burn is currently over 7 times higher in low and middle income countries than in high income countries. In India, over 10 lakh people are moderately or severely burnt every year. Burn injury, the most severe type of injury from a metabolic point of view, is characterized by the most profound alterations in basal metabolic rate and urinary nitrogen excretion. When the burn injury exceeds 15 to 20% total body surface area, that is DBSA, it results in systemic disturbances including a major stress response, impaired immunity, and massive fluid shifts. The severe muscle wasting due to accelerated proteolysis results in muscle weakness that predisposes the patient to pneumonia by limiting his or her ability to cough and clear secretions. Burns are complex injuries affecting the skin caused by heat, electricity, chemicals, light, radiation, or friction. Most burns only affect the skin, that is, the epidermis or the dermis layer. Rarely, deeper tissues such as muscle, bone, and blood vessels can also be injured. Burns may be treated with first aid in and out of hospital setting, or may require more specialized treatment such as those available at specialized burn centers. Severity of tissue damage can be classified as follows. That is, the first one is first degree burns. In this stage, the outer layer of the skin is affected, causing pain and redness. For example, mild sunburn can be an example for first degree burn. Second degree burn is, here it extends to the second layer of the skin, that is to the dermis. Here also it causes pain, redness, and blisters that may ooze out. Deep second degree burns may progress to third degree burns over the course of several days. The next is the third degree burns. In this, it involves both the layers of the skin, and it may also damage the bones, muscles, and the tendons. The affected site appears pale, charred, or leathery. There is generally no pain in the area because the nerve endings are destroyed. The fourth degree burn extends through the skin and the subcutaneous fat into the underlying muscle and bone. Fourth degree burns are stiff and charged. Burns destroy the skin's natural barrier to infection. So, the objective of the treatment usually involves preventing or treating in the infection. So, now we will see what is the mode of infection that is normally found in cases of burn patients. People who get burnt are vulnerable to infection. In a minor burn, it is difficult to detect whether the site is infected because the skin surrounding a burn is usually red and may become warm to touch. The potential signs of infection are: there may be a color change around the area surrounding the skin. The second may be the purplish discoloration along with swelling. Third will be change in thickness of the burn. Next, greenish discharge or pus from the affected area, fever due to the pain, dehydration. So, in severe burns, the fluid is lost through the skin and the person can become dehydrated. Dehydration may lead to life-threatening shock. Dehydration treatment is done with the help of IV fluids. I think you know IV is intravenous fluids. The signs of dehydration might include: the first will be the thirst due to the fluid loss, lightheadedness or dizziness mainly due to dehydration, weakness, dry skin, and urinating less than normal will be found. The next will be what is the treatment mode for these patients. Minor burns may be treated at home. All other burns require immediate medicinal attention because of the risk of infection, dehydration, and other potentially serious complications. Fluid restoration, electrolyte balance, and protein losses are of immediate importance during the first 24 hours. Patient should be put on parenteral nutrition to replace for the losses of tissue fluids, plasma protein, and electrolytes. In addition to parenteral therapy, patient should receive nasogastric feeding, that is 1 liter of fluid containing 5% glucose, 0.8% sodium chloride, and other electrolytes. On the reach of second day, parenteral fluids should be reduced to 50% of the first day's level, and oral fluids can be increased to 2 liters. For the first 48 hours, intravenous feeding is given with whole blood and glucose saline. Following next 3 days, high calories, increased protein tube feeding should be given, which is followed by full fluid diet and gradually increased in calories and increase in protein diet. After a burn heal, applying coconut oil topically may be helpful for reconditioning and moisturizing the skin. Now we'll see what is the mode of medication, what are the prescribed medication normally given for a burn patient. Antimicrobial ointments are used to reduce risk of infection. One study found that paraffin gauzes are valuable for superficial burns, while silver-based dressings are preferable for deep burns. Antibiotics are used to treat infection. Antibiotics may also be given in case of large body surface area of the burn. This is done since the risk of developing infection is high in such severe cases. Next is anabolic steroids may be used for severe burns to help decrease wound healing time. Managing burns is important because they are common, painful, and can result in disfiguring and disabling scarring, amputation of the affected parts, or death in severe cases. So, complications as such shock like infection, multiple organ dysfunction syndrome, electrolyte imbalance, and respiratory distress may occur. The treatment of burns may include the removal of dead tissue, that is debridement, applying dressing to the wound, administering large volumes of intravenous fluids, administering antibiotics, and skin grafting. These are some of the type of medications which have been prescribed for burn patients. Next we will see on the surgery and the other procedures which is performed for such patients. In case of severe burns, surgical procedures like debridement and skin grafting may be performed. Debridement means removal of dead tissue. Skin grafting, surgically sewing of skin over the affected area after the dead tissue has been removed. The skin can be taken from the person's own body, from a donor, or from an animal. Normally, the person's own body are normally suited and it is permanent. Artificial skin are also used. In case of say cosmetic surgery, it can be performed to improve both the function and appearance of the burnt area. So now we will see on the main other aspects which has to be looked on keenly for the burn patients. So burns management needs multidisciplinary approach with efforts from various specialties in the team. The dietitian in the burn team has a defined role in the care of burn patients from the acute phase followed through the rehabilitation. Their role in the assessment, treatment, and management of nutritional requirements with or without inhalation injuries is followed in the unit. Patients with 25% burns are characterized by high metabolic rate is elevated to 118% to 210% in adults, resting metabolic rate elevated to approximately 180%, calorie needs may exceed 5000 kilocalories per day. Without nutritional support, 40% burn patients lose 25% of pre-admission weight in 3 weeks' time. Impaired immunity and delayed healing may be seen. This characteristic metabolic changes associated with burns indicates the need for a nutritional therapy program from the day of the injury. So the goals and of the nutritional management might be to provide optimal wound healing and rapid recovery from burn injuries, minimize complications including infections, to attain and maintain normal nutritional status, to minimize the metabolic disturbances during the treatment process. And the objectives of this management will be provide nutrition via enteral route within 6 to 18 hours post burns injury, maintain weight within 5% to 10% of pre-burn weight, prevent micronutrient deficiency, minimize hyperglycemia, minimize hypertriglyceridemia. So now we will keenly look on to what are the nutritional considerations which has to be looked upon for this burn patients. So nutritional management is the key component of burn care. Nutrition is a major component of recovery for the burn patient. Patient suffering from surface burn of 40% can lose 25% of weight in 3 weeks without proper dietary support. Losses exceeding 10% are associated with significantly poorer outcome, including impaired immunity and delayed healing. Burn patients are in need of high amount of calories and proteins for wound healing, weight maintenance and infection prevention. Well-balanced diet is essential for healing of injuries and restoration of body weight. A low-fat, high-protein, high-calorie content is recommended. Weekly or bi-weekly assessments of nutritional status are advisable. Now we will see one by one the nutrient needs. To start with is calories. Elevations in metabolic rate ranging between 118% and 210% of that predicted by the Harris-Benedict equation occurs in adults with a burn covering 25% of total body surface area. Resting metabolic rate is approximately 180% of basal rate during acute admission, and the calorie needs may exceed 5000 kilocalories per day. As the subject will be at bed rest, their calories requirement will be slightly less than those of sedentary persons, but a majority of individuals lose body weight, which has to be made up by increased calories intake. So it is desirable to generally increase calories intake by 1.5 times the actual need. So the recommended daily energy intake is given here. Say for example, for adults it is 25 kilocalories per kilogram plus 40 calories per each % of burn area, and for children 1800 kilocalories plus 2200 calories per meter square of burn area. This increase will help in formation of new tissue protein. Weight loss is preventable with nutritional support. Individualized nutrition assessment is recommended for patient with burns on less than 20% of total body surface area. Next, we will see on the requirement of carbohydrates. Carbohydrates will provide the bulk of calories for the burn patient. Burn wounds require the glucose for carbohydrates for wound healing. About 60 to 70% of energy should be administered as carbohydrates. Care must be taken not to exceed the patient's ability to metabolize carbohydrate. It is particularly important not to exceed. So 5 to 7 mg per kg per minute in parental nutrition is given. The metabolic consequences of excessive carbohydrate administrations include glucose intolerance, increased carbon dioxide production, increased fat synthesis, and the development of fatty liver. In addition, fat synthesis is an energy requiring process, and overfeeding of glucose is energy inefficient. Food choices for a burn patient may include bread, cereal, rice, different types of pastas, crackers, potatoes, beans, sugar, peas, cornstarch, fruits and juices are normally recommended. And now we will move on to the protein requirement for burn patients. So burn patients need a very high protein needs because of increased protein losses through the burn wound, and there is need to provide enough protein to prevent the breakdown of muscle. The patient require twice the normal requirements because the tissue protein loss has to be made up. The protein oxidation rate is 50% higher in burn patients, and protein needs are 1.5 to 2 grams per kg of body weight. Optimal protein administration is essential since improved survival has been found with high protein diets. The NPE is to N ratio is also important. A ratio of 100 is to 1 is improves the survival over the traditional of 150 is to 1 to 200 is to 1 ratio. There are many formulae for the calculation of protein requirements, but many overestimate requirements approximately 2 to 2.5 grams per kg per day should meet requirements for major burns. Foods that are high in proteins include meats, poultry, fish, nuts, seeds, dairy foods and products, and eggs. Now we'll see on the fat and the lipid requirement of the burn patient. Fat is essential in diet after burns to provide essential fatty acids and additional calories. It should also be taken care that too much of fat, that is more than 30%, should not be provided through fat, since too much of fat can make the immune system weak. Although lipids are essential in the diet of burn patients, metabolism of fat is ineffective. In addition, oversupplementation results in immune suppression and fatty liver. Fat supplies at 15% of total energy, reduces infectious morbidity and shortens hospitalization time when compared with 35% supplied as fat. The correct mix of lipids is essential since omega-3 fatty acids are less immunosuppressive. Care must be taken with parenteral lipids. They must be infused slowly and lipid clearance must be monitored to ensure that triglyceride levels do not rise more than 10 to 20% over baseline values. The good sources of fat might include butter, cream, oil, salad dressings, nuts, avocados, and oily fish like salmon and sardines. Omega-3 fatty acids such as fish oil, 1 to 2 capsules or 1 tablespoon of oil 1 to 2 times daily can be given to help reduce inflammation and for healing and immunity. The next is the requirement of fluid. So this is very much important in a burn patient. Water loss can be as much as 4 liters per meter square per day, and a range of 30 to 50 ml per hour is given depending upon the urine output. And the micronutrients requirement, if we see, the vitamins and the minerals needs increases 5 to 10 times above normal needs in patients with burns. A multivitamin tablet per day should be given in addition to extra amounts of ascorbic acid, that is vitamin C, and vitamin K and vitamin A because of the role they play in the collagen synthesis. Levels of vitamin A, E and carotenoids fall below normal in burn injury patients. Vitamin C, that is 1000 mg 2 to 6 times per day can be given, helps in skin healing by enhancing new tissue growth and strength. Vitamin E should be 400 to 800 international units a day, promotes healing. Vitamin D synthesis is impaired in the skin of burn patients, both acutely and long term. Supplementation with the recommended dietary allowance of 400 international units per day has been suggested for patients with significant burn injury. Next, we'll move on to the requirement of minerals. So here, due to perspiration and vomiting, potassium, phosphorus, sodium and chloride losses occur. Therefore, electrolyte balance should be corrected by appropriate administration of fluid containing different electrolytes. A lack of certain trace elements, mainly selenium and zinc, can exacerbate poor immunity, and burns are the second leading cause of immunodeficiency after HIV patients. The addition of selenium, zinc and copper to a standard trace element formula and enteral nutrition was associated with a significant decrease in number of bronchopneumonia infections and with a shorter hospital stay. So the selenium and zinc plays a very important role in burn patient. So this is zinc requirement is very much necessary for wound healing and aids in speedy healing. The recommended dose of zinc is as follows. Say for example, for adults it is 15 mg, for children it is 3 to 10 mg, And now we will see the coenzyme Q10 is very important. Say 100 to 200 mg at bedtime for antioxidant and immune activity is given. And L-glutamine, that is 500 to 1000 mg 3 times daily for support of gastrointestinal health and immunity is given. There is some concern that people who are sensitive to MSG may also be sensitive to glutamine. So I think MSG is monosodium glutamate, nothing but the Ajinomoto what we consume. So next is the probiotic can help restore the balance, improving gastrointestinal and immune health. Yogurt is one of the best natural probiotic rich food. So now we have all seen with the requirements of different types of major and minor nutrients. Now we will see how this enteral nutrition support is important for burn patient. So enteral nutrition or tube feeding with high protein, high carbohydrate diet is recommended and timing may be critical. High carbohydrate, low fat diets for burn patients results in less proteolysis and more improvement in lean body mass compared with high fat diets. Feedings started with 4 to 36 hours following injury appear to have advantages over delayed feedings. Enteral nutrition will reduce the burn-related increase in secretion of catabolic hormones and help maintain gut mucosal integrity. The duodenal route is better tolerated than gastric feeding. Total parenteral nutrition is not recommended due to its ineffectiveness in preventing the catabolic response to burns. Total parenteral nutrition also impairs immunity and liver function and increases mortality when compared with enteral nutrition. So, nearly all burn patients experiences insulin resistance as a part of their hypermetabolic response and need to be placed on an insulin drip to maintain tight control of the blood glucose level. Now we'll see what are the projected complications of enteral nutrition. The most common complication with enteral nutrition is significant diarrhea. Diarrhea has been shown to correlate with the use of antibiotics, cimetidine, excessive dietary lipid content mediated by PGE1 and PGE2. I think you know what is PGE, that is prostaglandins, and diminished dietary vitamin A content. Other factors that contribute to diarrhea are hyperalbuminemia with gut edema, hyperosmolar tube feeds, histamine H2 receptor antagonist, antacids, particularly magnesium containing preparations are given due to inactivation of pepsin, bacterial overgrowth, test for Clostridium difficile and food deprivation. The incidence of diarrhea is also lower when enteral nutrition is started within 48 hours after injury and when continuous rather than intermittent feeding is used. So now next we will move on to how to assess and monitor the health status. So assessing and monitoring the nutritional status and the response to feeding is fraught with error and complicated. Traditional markers of nutritional status such as albumin and transferrin are influenced by the metabolic response and therefore not valid in burn patient. Daily weight in the acute phase are inaccurate because of dressings, fluid shift and removal of scar. The gold standard is nitrogen balance studies is confounded by large amounts of protein being lost through the wounds. The best option in third is probably to use prealbumin, which is less influenced by the acute phase response. If that is unavailable, it may be wise to do serial measurements of traditional methods and to plot trends. The combination of albumin, C-reactive protein, clinical assessment, weight and nitrogen balance may provide some indication of response to feeding. So now that we have seen on the different aspects of the dietary management, nutritional support which has to be given for burn patient, now I would like to conclude that severely burned patient have profound nutritional requirements secondary to the prolonged post-burn hypermetabolic and hypercatabolic response. Enteral nutrition support should be initiated early to optimize total burn care and decrease long-term morbidity. So, early enteral feeding within the first 12 hours after injury is an integral part of initial resuscitation of burn management. Early enteral nutrition should form the basis of the nutritional support and continue for 12 months after recovery. It is equally important that a progressive exercise program is combined with adequate nutrition to enhance restoration of muscle mass and strength. So, monitoring the nutritional status is not easy. So, clinical assessment of the burn patient provides indirect and often valuable information regarding the success of feeding and outcome of the patient. Thank you.